We are really pleased today to have Dr. Kaitlan Baston. I have loved talking to her. She really is very passionate about this work, and she was very drawn to this work. And she is very, very busy. She's got to leave on a flight in the morning at 7 because she's got a full clinic day. But she told me, I do not want to miss this opportunity to speak to this group because this is our target audience for the work that we need to do. So I've got goosebumps. I just can't believe her compassion and dedication. So a little bit about her. She's the medical director of addiction medicine at Cooper University in Camden, New Jersey, and assistant professor at Cooper Medical School of Rowan University. She looks like she's 17. In fact, one member of the audience said, you know, I know that you're older than you look, but, you know, she looks very young, but she's actually older than she looks. Oh, 21? No. She's dual boarded in family medicine and addiction medicine. She obtained a master's degree in neuroscience from King's College in London and graduated from Jefferson Medical College in Philadelphia. And she attended medical school because she wanted to do something about the inequities in healthcare. Through her work with immigrant and homeless populations and International Public Health Project, she directed herself to a career in primary medicine. And then she saw some of the issues in primary medicine and went back and did her training in addiction medicine in Washington State. And she's just visited Washington State and visited her friends this last weekend. She observed that both patients and medical professionals suffered from the lack of addiction medicine training in healthcare. So with the goals of community outreach, healthcare education, and hospital system improvement, she completed an ABA-M accredited addiction medicine fellowship. And then she decided they didn't need her out in Washington State because there were a lot of people trained. So she wanted to go somewhere where they really needed her. So she returned to the East Coast to begin her career. She currently practices in the Urban Health Institute, and she works with an interdisciplinary team of like-minded, driven individuals dedicated to making change in Camden. She strives not only to create a home for patients with substance abuse disorders within the medical system, but to end the stigma of addiction in society and ensure that all patients suffering from substance abuse disorders are offered treatments that can allow them to live full and satisfying lives. So without further delay, I'm going to ask Dr. Baston to come up and speak with us. And this group will love the fact that she has a 2-year-old and another child on the way that will be here in December.
Thank you so much. That was a wonderful introduction. Thank you so much. And thank you, everybody, for having me. A couple things to start. I really like, even though I know we're all sitting in a big audience, to have audience participation because we're adult learners and it's the end of the day. And so we are going to do some things that are interactive. At the end of the row, in the middle here, there are stacks of index cards. If people who are sitting there could find the little stack and just make sure they pass it down, everybody just needs one index card for the talk. And do most people have writing utensils? Great. Okay, good. So make sure those are passed around. I will ask for people you'll just do some writing, you'll do some trading, you'll do some speaking if you're brave, and we'll get through this talk together. It is, as she said, a huge passion in my life. And I do this work every day. I take care of pregnant women with substance use disorders, and I then follow them after they've had the babies, and I take care of postpartum women and their children and their families. And I can't tell you how rewarding the work I do is every single day. It's just incredible to watch people get better. So I'm going to share with you a little bit of the information I learned in my training, some national guidelines, and we'll go through this together. So The focus today, I was asked to talk specifically about medication-assisted treatment, and we'll talk about what that means and the diseases that treats. And just in general, we're going to talk about perinatal substance use disorders. So I'm using a Prezi. I don't know if people have seen this before, but other than apologies for those who have motion sickness, I have no disclosures. It will move a little bit, but it's not that bad. So we're going to go through, and I'll give you kind of an outline. We're going to start big picture, where the bubbles are kind of big at the top, and we're going to go into some more details as we go through. We're going to start by just doing an overview of perinatal substance use disorders, how this affects women and their families. Then we're going to go into more of the details of assessing risk. So what are the real risks associated with this? And then we're going to dive into the details of medication-assisted treatment. Before I start and get into it, I would love to just do a quick survey of the audience. You're allowed to vote for more than one of these if it's too difficult to choose. But basically, I just want to know where people's focus is, what really would help your work, the work that you do every day. So I'm going to go through, I'll give you a second to look at these, and I'm going to read them. And for this one, we're just going to do a show of hands. So if I read something that seems particularly compelling to you, please raise your hand. So are you very interested in A, just the definition of medication-assisted treatment and medication option for pregnant women? And how about B, detox versus medication-assisted treatment for opioid-dependent pregnant women? Okay, huge interest. Great. And then how about C, understanding the risks of maternal substance use to infants and their children? Okay, excellent. And D, knowing the difference between recommended treatment for pregnant versus non-pregnant patients. Okay, great. So how pregnant patients are different from other patients with substance use disorders. And how about E? Anybody have like a primary thing that is not on here that you would love for me to address today? Yes. Great. So that is not in my talk, but I can talk about that. We do that regularly, so I'll squeeze it in if I have time, or we'll do that as a question at the end. Yes. Yes, great. We'll talk about that. One more. Yes, I will talk about that. Great. Okay, excellent. Thank you. That gave me a great idea. We'll focus. It means, to me, this means that I can breeze through some of the intro. I'm going to talk a lot in the intro just about just some general feelings and how we address these patients. Okay. So let's start just with a patient case, okay? The patients that I see when they come to my office, they've made it to medical care, but as we know in society, that's not always what happens. So this is a case that came to me through the justice system, actually. She was a 28-year-old who was arrested for having paraphernalia in her car when she was pulled over. And she was going to be taken to jail, and then she was very nervous and told the officer she was pregnant, she was using heroin, and she was really afraid to go to jail because she was afraid that what that meant for her and her baby. And when she had talked to them and eventually talked to my team after getting discharged from jail, she said, like many of my patients, I don't want to do this anymore. I've not wanted to do this for some time, and I just can't stop, and I was terrified to tell anyone I was pregnant. So this is just some statistics. I don't have to tell people in this room that this is really common. This is specifically looking at opioids because that's, a crisis, something we're in right now. And it's one of the reasons that we recommend doing screening for all substance use disorders. As you know, fetal alcohol syndrome is something we look for, but also opioids. We have treatment for this, really good treatment. And so we should be screening. And just doing surveys, we see that it is prevalent in both the below the poverty line, as this graph shows, and above the poverty line. While it is more prevalent in people below the poverty line, it still is there for people above And, wealthy families, it's, as you know, pervasive now in society. So when these mothers, come across our care, what are they feeling? What are they going through? And the reason I think this is important is we can't reach them if we don't have any idea what they're going through. And I will say that when I see patients, by the time they get to medical care, I tend to see them in kind of two very distinct patterns, although, of course, everyone's individual and has a unique story. But overwhelmingly, I see women, the primary emotion I see is shame. Tons of guilt, tons of shame, enough to keep them from feeling like they can get care, from feeling like they can tell people what's going on. I hear things like, I just wanted to quit before I went in to get care, because they don't want to go in and say they're still using any substance. They believe they're horrible. I'm a horrible mother. I must not care about this baby because I can't stop. I also see fear, overwhelming amounts of fear. They're going to take my baby. I can't tell anybody about this because I'm going to be separated from this child. Or, like many mothers, something's terribly wrong with this baby. We all have nightmares about something happening, and you can only imagine if you're struggling with a substance that those are very pervasive. And then even denial. Some women just can't believe that this is going on. It would be such a terrible thing. Like, no, there's no way. I can't possibly be pregnant. And some women come to me very late in their pregnancy. The other way that I sometimes see women, which honestly is almost equally as concerning, is that they come to me and they say, I'm fine. Like, I've been using for 5 years, but now I'm pregnant, so I'm just going to stop. Like, I'm never going to use again. Not a problem. And that honestly is concerning to me as well, because if it were just that easy, people would just stop. Like, it wouldn't be an issue, right? And I totally feel this dedication and the motherhood and what they want to do, and I just want to make sure that I'm caring for those women as carefully and kindly as I am for women who are scared and on the other end of the spectrum. So we kind of think about what women are going through and they're coming to us, but it's also really important to think about how we're feeling, because this care can be triggering. It can bring up lots of emotions. In healthcare, we have this saying, which is if you're going into a life and death situation, the first pulse you check is your own, right? And we use this because if your heart is racing and you're going crazy and you don't have clear thoughts, then of course it's going to be really hard for you to calmly run an emergency situation. And while that's true in just, plain emergencies, like in the emergency department or trauma, it's also true in emotional emergencies, right? And if we have a lot of countertransference, if we're carrying a lot and bringing a lot to these visits, which we will bring some, we have to identify that, or we're going to make interesting decisions that may not always be in the best interest of our patients. So when I ask care providers, when I ask police officers, I've given this talk to the Camden Police Department and talked to them about it, I ask, like, what do you feel, when you see this? So I'm actually just going to read an excerpt really quick to you, because I was about to give this talk in Pennsylvania last year, and I was giving this talk to a Nurse Family Partnership organization, and someone sent me this article that was just published in their local newspaper because they wanted my opinion on it. And I'm going to ask for your opinion on it as well. So I'm just going to read this. The babies are going through a draw. It's that simple and that horrible. That's why they tremble and sweat, have blotchy skin and rapid breathing, endure seizures and struggle to sleep and gain weight. That's why they feed poorly and vomit, have diarrhea and don't sleep enough. That's why we support a task force to study how heroin and prescription drug addiction ravages infants, particularly how it hooks them in the womb, leaving their ravaged little bodies to suffer the repercussions after birth. So I would just like everyone to take a second and take that index card that I passed out and just write one feeling word on that card that you have after hearing that newspaper article. And when you're done, just fold that card in half and kind of hold them up so I can see people are getting ready. And then I'm going to ask you to pass these cards 3 times. So just make 3 switches with your neighbors. So hopefully by the end, nobody's holding their own card and they're making their way around the room. Thank you, everybody. That was great. Just got to keep the juices moving in these evening talks. So, could. So now that we've done this and you're holding, there's no shame or concern about the words that you're holding in your card. They're not your own feelings. Do you mind just opening that up and anybody just shout out what somebody was feeling on that card? What's that feeling word? One-sided. Blame. Horrific. Sad. Anger. Tragic. One more time. Painful. Yes. I had all those same feelings. This is not my favorite piece of literature. But just to let everybody know who doesn't know, what they're describing is called neonatal abstinence syndrome, but it's specifically untreated neonatal abstinence syndrome, which is unethical and wouldn't happen in an appropriate treatment situation. I'm not saying that doesn't happen places in the country, but that means that the care providers who are caring for those babies are not doing what they're supposed to do. Okay, so this should not take place in our country. We should have enough education to know about NAS, to treat it appropriately, and we don't actually allow that to happen to babies. Now imagine you're a pregnant woman and you have been struggling like many of my patients. You were prescribed Percocet for an ankle, injury that you had, and then you developed a dependence and then a use disorder, and now you're using heroin, okay? I hear the story 20 times a day. So then you become pregnant, and then you read this newspaper article. You're gonna be carrying those emotions, you're gonna be carrying that around with you times 100 all day, every day. And I can't even imagine being brave enough to then go to tell somebody I just did that to the baby, to the person that I care about so much, right? So when I hear people talk about these patients, they say things like they're criminals, they're high risk, they're unfit to parent. And the truth is they're people and they're struggling with something, and our society sees it this way. And I just want to make sure that we all recognize that the feelings that we have, which we're going to have because this can be sad, it can be tragic for both parts, are going to affect the way we talk to our patients. So this is just to say that these women face tons of barriers, which in this treatment, we all know, right? There's fear of judgment and stigma. There's also a lot of lack of social supports. Women who suffer from substance use disorders and become pregnant are often ostracized by society because of that. And also, they become ostracized from their using community. So they used to have friends and they had people and they were, they might have been using with or surviving with. And now those people don't want to hang out with them anymore either because they're using and pregnant. So they end up very, very isolated. And then they're going through the physical and emotional challenges of pregnancy, challenges of parenting, all those things, maybe in a very difficult environment. So how can we better reach them, right? How do we do a better job? Number one, incentivize getting help. So the opposite of criminalizing this, but rather allowing it to be open, allowing us to have systems in place where women can easily get help. Number two, push for evidence-based treatments. So in the addiction world, one of the reasons I went into this field is that it has some interesting history, the history of addiction, and it hasn't always followed medical science evidence, right? That's just to say there's some bad treatment out there, like really bad treatment, and stuff that doesn't work and has been shown not to work, and we're still doing it. But most people don't know the difference, right? And so part of this is learning the science, learning the difference, and saying, how can I look at what my local resources are and promote the ones that are using evidence-based treatment and not the ones that aren't? Okay, and then number 3, improve that access to that evidence-based treatment. So again, quick just show of hands. How many people come from an area, and this may be a very local conference, I'm not sure, but how many people come from an area where a woman can be prosecuted for having used substances in pregnancy? Maybe a few. How many people aren't sure, or it feels like a gray area?
Our state had a statute in sunsetting. The statutes that exist now, you've got to get kind of creative and really depends where you are in the state.
Okay. So I bring this up just because this is something that does still exist in some places, and that, you know, if a woman is afraid that she'll be arrested or afraid that she'll be in trouble because she has this issue, it's really just another barrier to get help, and it's interesting to know what the legislation is around your area.
If you ask how many of them are going to end up in the child welfare system, that'll be a different question.
Yes. So, on a public health level, right, someday we'll get to the place where we're doing universal screening. This is already recommended, okay? So ACOG, you know, the Society of Obstetrics and Gynecology recommends this, but it's not being done. It's very rarely being done. There are 2 ways to do it. You can do universal urine screening at prenatal visits or when a pregnant woman comes into any kind of care, or you can do a verbal screening tool, and there are evidence-based verbal screening tools. So if you're implementing something like this, there is a screening tool you can use. The one we use at our institution is called the 4 Ps. I really like it because it's a non-judgmental way. It kind of also gives you a lot of information about the person's environment, because we ask the pregnant woman, did either of your parents ever struggle with drugs or alcohol? How about your partner? In the past, has your life ever had challenges because of substances or alcohol? And then in the past 30 days, have you used any substances or drank any alcohol? So we use this, and we're doing universal screening right now in our emergency department. We're pushing it out to other parts of the hospital, but it's a big challenge. And I think of this as like this beautiful future state, right, where we're screening everybody, just like I got screened for diabetes in this pregnancy, right, and where at some point everyone will just get this screening and it'll be treated like a disease just like my current diabetes is in pregnancy, right, and I could just say, I have diabetes in pregnancy, and people don't think I'm a terrible mother because I can get treatment, I can get help, I can get medicine, and I'm seeking that treatment and help in medicine. But we're not there yet. You know, we're not screening everybody. So people are going to be just like our case. They're going to come to us through the justice system. They're going to come to us from, you know, their neighbor is going to call, somebody's going to do something, and they're afraid to get care. So what does this mean, right? What does this mean for this mother? What does this mean for this child? And even if we screen, you know, and we pick this up early, what does this mean? And this is where I really want to just move into the assessment of risk. And this was a big interest for a lot of people in this room. And I'm going to go over the science that I know. I'm also happy to answer questions at the end or share, you know, what other people know. So we're going to do a quick quiz. It's a pre-test in a sense, just to get some idea of what people's, this is very medical, but just kind of see what pre-existing knowledge or considerations are. So we're going to use those index cards again. Okay, I'm going to read through these twice, and so the first time you can just listen or you can read on your own, and you know, just pick which one of the following 4 is a true statement. Only one is true. Okay, either A, B, C, or D, and just write the letter of that on your card. So is it A, gestational cocaine exposure alone has not been shown to cause neurocognitive deficits in longitudinal studies? Is it B, fetal alcohol syndrome occurs in approximately 70% of cases with documented heavy drinking in pregnancy? Is it C, opioid-dependent pregnant patients should be counseled to stop opioids immediately to avoid risks associated with opioid use? Or is it D, gestational exposure to opioids increases the risk of addiction in a child's lifetime? Do people need me to read them again? I think you got it. Just write A, B, C, or D down. And when you're done, fold that in half and pass it 3 times. Okay, everybody have a card in their hand. So again, you're just holding a random card. So we're gonna get hopefully a true survey of the audience, right? So everybody open this and you don't just raise your hand if you have the letter of this number on your card, okay? Or the letter of this on your card. So how many people have an A on their card? Go, audience. How about a B? How about a C? And how about a D? Okay, that was pretty split. There was if people couldn't see, there was a pretty, I would say the majority had A, raised their hands, but there were still a few C's, a few B's, and then quite a few D's. So the correct answer is A. You beat all of the doctors that I give this talk to, I just want to say. I give this talk a lot. Doctors don't know that. So that's fantastic. The truth is that a lot of these are, things that we think or don't know or may have heard, so we're going to go through some of this evidence. So in the medical world, right, when a woman is pregnant and using substances, there are 4 main categories of risk that people talk about. There's teratogenicity, right, so birth defects. I will tell you, this is what I think every mother, but mothers have running in their head. They're like, my baby is missing an arm. Like, something is wrong. My baby's deformed now. And the reality is the risk of that is probably very low, depending on the substance, other than alcohol. The other thing is obstetric problems. So these are actually real risks that mothers don't always think about, and doctors, I do worry about. So these are risks to the pregnancy. So that means, is she going to carry all the way to term? Is she going to have an early baby? Is she going to have a small baby? Are there going to be problems with the pregnancy itself? Then there are questions of fetal development, and I think a lot of us, think and worry about that for the future. And then there's this neonatal abstinence syndrome, and a lot of people are really worried about NAS. And then, of course, we're adding on to that psychosocial concerns. Is there housing available? Does the mom have the ability or desire to parent? I will tell you, most of my moms have the ability and desire, but they really need a lot of psychosocial supports to do that. And, of course, that only happens in recovery. And then there's the lack of social and family support that we talked about before. And all of this can contribute to, is this fetus going to be okay? So you're going to get an entire talk on fetal alcohol syndrome, so I don't have to go into the details. I'm bringing this up mainly for historical context, okay? So FAS was relatively recently described in medical literature, just in the 1970s. And the interesting thing that happened after we identified this is we found out that alcohol causes birth and developmental defects, right? So we discovered this as a society. Of course, we're very careful. We've done a ton of education around this. And kind of naturally, the interesting thing that happened after that is, as a society, we think that alcohol is not as bad as heroin, right? Alcohol is legal, heroin is not, right? It's not as bad as methamphetamines because they're, The thing is, in pregnancy, that's not necessarily true, okay? And so what happened naturally is like, well, if alcohol does this to babies, what does crack do, right? This is where our minds go. And a lot of this, I just wanted to give you this historical context, is a social context, right? Not necessarily a scientific context. And so when we're thinking about this, yes, substances all have risks, but we need to know what those risks are. And alcohol's risks are specific to alcohol, okay? So we've done studies, many studies, because of course people want to know, like, well, what happens with marijuana exposure, with sedative like benzodiazepine exposure, with opioid exposure, specifically looking at teratogenicity, right? So looking at birth defects is what I'm talking about right now. Of course, we can't randomize women and give them marijuana. So we really only have at our disposal not the best scientific evidence, they're retrospective studies. But interestingly, even though we've done studies after studies, and you'll see them, and you might see them in headlines, and you might see them over and over again, none of them have been able to replicate that any substances other than alcohol have a real teratogenic risk. Okay, so some studies will find that they do, but other studies will say they don't, and so we cannot say that they do. It's interesting because in the opiate literature, when you read all of the opiate literature, the only one that kind of consistently comes up as maybe having a signal for teratogenicity is codeine. And when I ask people, like, what's the not bad opiate, they're like, oh, I just gave her codeine. But actually, in pregnancy, that may be the one to avoid. So I just think this is interesting. Again, just look at the science, see what's out there, and kind of understand what the real risks are of birth defects. So the big take-home I have for you is of the substances we're talking about, right? Sedatives, marijuana, stimulants, nicotine, opiates, and alcohol. Alcohol is the only one that has been reliably shown to cause birth defects, okay? I think this is really interesting from a societal standpoint, but also I think this is really important to talk to patients about. So they have all these fears, right? They're worried there's a defect of their child, there's something wrong with their baby, and being able to say, like, you know, science doesn't tell us everything, we don't totally know, but this is what we think from what we have, the evidence we have. And it's not that surprising to medical professionals, because alcohol is cytotoxic, meaning it kills cells at certain levels, and other substances don't work like that. So if a fetus is developing and we have a substance that's going to kill cells in development, it may cause birth defects, whereas other substances may not, right? So what about neurodevelopment? Again, right after FAS was described, there was a big boom and epidemic of cocaine in the 80s. And the literature really mimicked a lot of what we're seeing today, a lot of what I read to you with the opiates. Their mothers use drugs, and now it's the children who suffer, right? And a lot of this came in society. And the truth is, you know, this was an epidemic. Yes, mothers and children and families suffered, but, you know, what were really the long-term implications of just gestational exposure to cocaine? So luckily, we have some people that spent their careers in medicine looking at this. There's one woman named Halem Hurt who studied this. Was from the Philadelphia area, actually, and studied this through her whole career and followed children throughout adolescence who had cocaine exposure in utero, okay? And really amazingly, what she found and what was published in JAMA after looking at her studies and others were that when you correct for poverty, drug use in the home, education, all those things, there was no difference between babies who had exposure to cocaine and babies who did not. So it doesn't matter as much what happens in the womb. It really matters what happens when the baby comes out, okay, with this particular substance. All of the studies have confirmed that growing up in a using household affects intelligence and emotional well-being, okay? So we really want to focus on the environment, and it really matters, that sober environment for child raising. And yes, it matters if the mother's using for her sobriety, right, for that sober environment and for the pregnancy. But those words that I've heard in the beginning, like it's a lost cause, the damage is done, that baby is now broken or affected, is not necessarily true, okay? And what about the child's future risk of substance use disorders? So this is another thing that moms ask me all the time, like, you know, if I'm on methadone, if I'm on buprenorphine, or because I used opioids, does that mean my child's gonna be an addict? And I hear people say to me, like, those babies were addicted, right? You heard in this statement, it hooks the babies in the womb and they're addicted, they're baby addicts at birth. There's no such thing as an addict baby. Okay, they're infants, they don't have addictive behaviors, okay, that's not what addiction is. They may be physically dependent and they may have a physical dependent syndrome, but they're not addicts, okay? And we can talk about the difference a little bit more to make that more clear, but you're going to see this throughout my talk. When you see that regulations.gov, this is the national guidelines that came out that really looked at opioids specifically. But I think this is really great because we had enough evidence to say, specifically for opioids, that gestational exposure and even the experience of neonatal abstinence syndrome itself does not increase the risk of addiction in a person's lifetime, okay? Genetics do. So even if the mother didn't use at all, but her father had a severe substance use disorder, that baby has an increased risk from genetics, okay? That is separate from gestational exposure. So what I counsel moms on is you have this runs in your family, and if you've had this issue, it runs in your family, okay? So that means you can counsel your kids on that and whatever, but the exposure itself doesn't increase the baby's risk. So that baby just has the same risk as they would have from the genetics, okay, whether they were exposed or not in utero. The other thing, of course, is environment that does affect that. And so if the baby grows up in a using environment or is around that, then that affects their risk. It's nature, nurture, same thing. So this is all to say that we really, in medicine, want to shift the focus away from criminalizing gestational exposure or, thinking about that. We do think about it for alcohol. We definitely think about it for the pregnancy, but not like this baby is now damaged, right? But move the focus to preventing obstetric harms and promoting a sober environment for child raising, okay? The real risks are obstetric. So these are the big risks that we see from substances. It's intrauterine growth restriction, which means the babies can be small, early delivery, placental abruption, which is a risk that happens when the placenta separates from the wall, and that can cause bleeding, early delivery, small babies, all those problems, infectious disease exposure. Interestingly, poverty, trauma, and poor nutrition also have those same obstetric outcomes without substances, just those alone. So when we look at this population, if they're also having those things, then we worry about risks. Nicotine increases those risks. Stimulant use increases those risks. And here's the interesting thing with opiates. Exposure to opiates does not increase those risks. Withdrawal does. So if a woman has used opiates or has opiates in her system, that doesn't mean that she's increasing those risks alone. So you can be prescribed, for example, oxycodone in pregnancy. The exposure doesn't cause those risks. If you become physically dependent, the fetus also becomes physically dependent, and then withdraw from opiates causes those risks. This is a medical study that I'm just going to talk about briefly. I love it even though it's an old study because it's one of the only studies that controlled for smoking. When you see a lot of substance use studies or substance use disorders, there's a ton of smoking that goes along with that, and it's really hard to separate out what's the risk from cigarettes, what's the risk from other substances, and this was stimulants, which we know act kind of similarly to nicotine. So they had very large numbers, and they looked at outcomes from gestational cocaine exposure and nicotine exposure. So the cocaine was without nicotine, and the nicotine was without any other substances. The interesting thing was, again, the same risks that we talked about, preterm labor, low birth weight, and a risk of fetal loss or death. The risk with nicotine were the same as the risks of cocaine. The risks of cocaine just happened more frequently. Does that make sense? So at a greater magnitude. But when you look at the population and the number of women who smoke compared with the number of women who use cocaine, we're way more likely to see this in medicine because of nicotine. So all these same risks are going to happen because of nicotine. And again, we don't think about like we're going to lock women up because they're smoking. We think we need to help this woman stop smoking, right? So again, on a population level, smoking is as important, if not more important, and we should be doing the same things and the same kind of treatment approach to these substances to avoid this. Just diving into nicotine a little bit, I bet the people in this room know this, inside and out, but it accounts for a lot of problems for babies and for pregnancies. So preterm deliveries, SIDS is a big thing, and preterm-related infant deaths. And those are fairly large percents on a population level of those things. The good news is that 55% of women who smoke quit during pregnancy, so there's a high motivation. I think we can do better, but that's a pretty, positive number that women are very motivated. Sadly, a lot of women then resume in the 6 months after, and so it's one of those very important models. We have to be following women after pregnancy and beyond to kind of really, really treat these things. Nicotine, just like all these other substances, it's a chronic disease. It's around. It doesn't just go away when you stop. So I'm going to focus a lot on opioids now because this is a current epidemic, and this is where we have a lot of medical treatments that can really help. So just an overview for opioids. Low risk, if any, of birth defects, okay? Use does not cause risks. Withdrawal has potential risks in pregnancy. Opioid dependence develops in the mother and fetus, like we talked about. And of course, illicit use and injection use has known risks, health risks in general. So for those of you who don't know what the symptoms of opioid withdrawal can be, any person, but in the mother, early signs of withdrawal: agitation, muscle aches, your eyes run, your nose runs, you yawn, and you can have sweating. As it gets more severe, you have terrible abdominal cramping, diarrhea, vomiting, and this is what can happen in any person who's opioid dependent. It feels like the worst flu of your life. Basically, it feels just like a terrible, terrible flu. And when they've done some studies, what they've seen is on the fetal side, when the mother's going through withdrawal in pregnancy, is increased movements, passage of meconium, which means the baby passes its first feces inside, which can be a risk of stress, preterm delivery, miscarriage, and even in some cases, fetal demise inside, fetal death. So what do we do about that? Right? Here's the question. So this happens when somebody becomes opioid dependent. That can happen if you're prescribed oxycodone or if you use heroin. It doesn't matter, right? Our bodies adapt and become dependent on opioids. So you might see women with chronic pain who become pregnant and have the same thing, right? So what can we do to safely treat this? So for addiction, there are kind of two different ways to treat, and we were talking about this, right? What besides medication do we do? What are the different levels? So there's medication, right? I'm an addiction medicine physician, so I focus on the medicine. I have a medical specialty clinic, and I take care of the patient and the whole family around the medicine component. And then we also work with drug and alcohol counseling, behavioral counseling, therapy. And there are so many different levels of this, okay? There's individual counseling, there's group therapy, there's what we call intensive outpatient treatment, which is typically 3 hours, 3 times a week, outpatient somewhere, like in an office. Then there's partial care or partial hospitalization, which tends to be 5 days a week most of the day. So people can basically go to school as an adult and be in school 5 days a week. Then there's inpatient treatment, which tends to be short. For whatever reason, insurance companies have decided 28 days is the magic number. And then there's long-term residential treatment, which means somebody goes to live somewhere long-term, okay? So these are all ways that we can do kind of wraparound psychosocial care. When we look at substances and when we look at medication-assisted treatment, the substances that we have great medicines for right now are opioids, alcohol, and nicotine. Really, unfortunately, sadly, we do not have great treatments for stimulants, like medical treatments. We're doing trials, we're trying over and over again, but nothing's really panned out. Marijuana and PCP, similarly, not great medicine treatments. We're getting there, and there are some things on the edge, but nothing's really shining. Okay, and then medication-assisted treatment means that we're using medicine and we're doing other wraparound treatment with that. Interestingly, in the literature with non-pregnant patients, okay, they've tried behavioral health alone for some of these things, like opioids, for example. Opioids are the big one right now because we have great medicine treatment for it. When they try behavioral health alone, it only works about 10 to 15% of the time, okay? Medicines can bring that way up, depending on the medicine, at least to 20%, and then 60%, and then 80%, okay, depending on the medicine. So that really helps. That medication-assisted treatment really helps. So what are the medicines out there for opioids, okay? Focusing on our current national crisis, we have great medical treatments. There are 3. There's methadone, which has been around for a while, again, since the 70s. There's buprenorphine, which is relatively new for this. It came about in the thousands. And then there's depo-naltrexone, which is Vivitrol. Some of you may have heard of that. So, quick show of hands. Which of you think, in the audience, we're going to talk about treatment retention. So when you use these medicines, which medicine has the highest treatment retention rates? Meaning you've given this patient this medicine and they're the most likely to stay in treatment, okay? Is it methadone? How many people think methadone? How many people think buprenorphine or Suboxone or Subutex? And how about Vivitrol? Okay. I'm going to show you this graph really quickly just for those of you who are sciencey or interested. They work very differently. Okay, methadone is what we call a full agonist at the opiate receptor, which means it goes in, hooks on those receptors, and turns them on all the way. I talk to patients about this like a doorway, right? Goes in, opens the door all the way, and just kind of holds it there. And the way methadone really works is it floods the system, and it kind of equalizes people like that. And then if they use other things, nothing really happens, if that makes sense. If you use other opioids, the system's flooded, all the doors are open, it's there, you're stable in that way, okay? You're also, if you have too much methadone, you might be sleepy. It's all in the system. It's not giving you a big high and a low, right? You're not getting a high. You might be sleepy if you're on too much, but it's not the same as having an abrupt high or injection, right? And methadone, because of that kind of the way that works and flooding the system, that long-acting thing, it just hangs around and makes people less likely to overdose, and they don't go like this throughout the day, and that's how it keeps people stable. Buprenorphine is what we call a partial agonist. This is very, very simplified science, right? But when I tell patients, it opens the door a fraction of the way and holds it there really tight. And the way that works is if you're used to having all your doors open, and because you've been using for a while, say some people have, when you were born, you had 10 doors, and you've been using for years, and now you have 100 doors, right? And so if you don't have anything, those doors are just sitting open, and you're sick. That's the withdrawal, right? You're dependent, you've increased all the numbers of doors you have, and you have nothing to fill them. So you're physically sick. So by going in and hooking on those doors, we can stop that sickness, okay, either with methadone or with buprenorphine. And so we stop that sickness, and then with buprenorphine, it holds onto those doors really, really tight and opens them just a little bit. And by holding on really tight, it doesn't let other substances in, okay? It kind of keeps them at that small action, and it also has a ceiling, meaning you could take more and more buprenorphine, but nothing would happen. It's only going to open those doors a certain amount of the way, okay? So it has a ceiling. It's kind of complicated science, but it just basically means it's a safer opioid than other opioids, okay, which is why we can prescribe it the way we do. And then there's the Vivitrol or naltrexone. That's different. It's a blocker. So it doesn't prevent any withdrawal. It can actually create withdrawal if you give it when someone's dependent. But it goes into the system, holds on, and just holds those doors shut. So it doesn't let anything in or out, okay? So we did this survey. Here are treatment retention rates for these various medicines, okay? So science shows that basically people on methadone have about an 80% treatment retention rate, buprenorphine about a 60%, Vivitrol about a 20% treatment retention rate, okay? So when you're counseling patients or choosing these treatments, you kind of know what is going to keep people engaged or keep people in treatment. Vivitrol right now is not recommended in pregnancy. They need to do studies. They don't know whether it's safe. So the two that we use in pregnancy are methadone and buprenorphine of these medicines. Which one is better, okay? There's a lot that goes into this decision. It really depends on the kind of treatment that woman needs. When you look at the fetal outcomes, there was this amazing trial called the Mother Trial. For those of you who know medical research or science, this was a double-dummy, double-blind, randomized, multi-site international trial. It's a really good study, okay? Really good. And they looked at all centers all over and internationally, and this is basically what they found. They were looking at neonatal abstinence syndrome rates when fetuses were exposed to either methadone versus buprenorphine, okay? The incidence of NAS was not statistically significant, so that 47 to 57%, that was not statistically significant. So about the same percent of babies actually had neonatal abstinence syndrome. They can't comment on whether that's, actually matters. But the amount of morphine that they needed to treat it and the length of stay they had to be in the hospital was significant, okay? So if buprenorphine works for a pregnant woman, the fetus is less likely to need as much medicine or need to stay in the hospital as long. If it doesn't work and she's still using heroin, then it's not good and you want to use the other treatment. So methadone can be really effective and is safe for babies, okay? So here's the big question, right? A lot of people want to know this. Well, do all women who have opioid dependence have to be on medicine? Can we just detox them in pregnancy so that the babies don't have to have NAS, okay? So here are the risks, just to know the real risks of detox. The major risk for any patient with opioid use disorder of detox is overdose. If you have detoxed somebody from opiates and they're no longer tolerant and then they use again, even a tiny amount, they can overdose. That happens from people coming out of jail, right? That happens from people coming out of treatment. So we put them in a detox center and then they come out and then they slip. Even once, they die. That's really scary, right? The major risk and typical outcome is relapse. So the reason that we say we should offer these really good treatments is that when you don't and you just detox women, they have a much higher rate of using again, okay? There's also no known way to ensure fetal safety. Lots of studies come out, lots of studies say we've had women in these controlled environments, we've monitored the babies, we've gotten them off the medicine. If you really read into those studies, a lot of those babies still have NAS because the moms have relapsed and the babies still have NAS, so that's not a safe treatment. And we do know there are risks obstetrically, and to me, even a tiny risk is too much to do on a big population level, okay? Moms will say, I just want to get off everything. They'll come, they talk to me about it, and it's not that, I'm just going to say, no, you'll never find a doctor who will do this for you, because there are doctors who do, okay? But the thing is that there are studies and studies and studies, and this has been known this is an old ACOG. I put this in on purpose because it's been known since 2012 that the current standard of care for pregnant women is opioid-assisted treatment. It's medication-assisted treatment, buprenorphine or methadone. That's in the national guidelines. This has been said for a while, so I'm just following the national guidelines, and that's why I say we shouldn't detox women, okay? Medically supervised tapers of opioids often result in relapse to former use, okay? This is all in this paper since 2012. And then NAS is an expected and treatable outcome, right? So if we treat it, those things that they said in that first paper don't happen, okay? We don't let babies seize. We treat it appropriately. This is treated in the hospital. When I tell moms, when the baby's inside, I can't monitor the baby and give the baby exactly what it needs, and I don't know exactly how to do that taper. When the baby's on the outside, it's a little bigger, it's more robust. We can watch the baby in the hospital, and we can give the baby exactly what it needs and do that appropriately. Right? So that's what we prefer to do. And this is from the national guidelines, basically just saying that medically supervised withdrawal is not recommended. So here's the other big question, right? Once you get on maintenance therapy, is it forever? Do you have to be on it forever? And moms say this to me all the time. They're like, okay, I'm willing to go on this medicine for pregnancy if it's the best thing for my baby. As soon as I have the baby, I'm gonna come off. And when they say that, I look just like this baby, is how I feel inside. I try not to show that on my face, but I'm like, oh no, oh my gosh, okay. And the reason is just that the medicine really works, and right after you have a baby, you're so vulnerable, right? You're tired, you're not sleeping, the baby's not sleeping. Like, if you can think of a time that a mom is gonna relapse, that is the time. She no longer has that protective feeling of the baby being inside, right? So this is when she needs medicine more than ever. So they've done studies after study to say, how long should somebody be on this medicine? The truth is, most of the studies have been showing the longer, the better. And like, if you detox somebody in 6 weeks, it's not as good as if you've kept them on for 6 months. It's not as good as if you've kept them on for a year. This is a chronic disease. We don't know that it's forever. Everybody with chronic diseases are different, but we do know that they need a significant amount of time to be treated for a chronic disease. This is a study that's really interesting. It was an early buprenorphine study, okay? And it's in here because I just want you to see what it looks like when people are randomized to either staying on buprenorphine or being tapered off. So this was a double-blind study, okay? So it was blinded, and everybody got medicine in a hospital for 16 weeks. They all got buprenorphine, and then they randomized certain people to being tapered off, and a different group and getting placebo, and a different group to staying on buprenorphine. We couldn't do this study again. It would not be ethical, okay? So here's the treatment retention rate of people who stayed on buprenorphine. That's the top line. That bottom line are the people who were given placebo, okay? So if we stopped their buprenorphine, they fell out of treatment. They followed these patients for a year, which is also really rare, okay? So in order to maintain women in care and maintain treatment, we don't want to taper them off right away, basically, okay? This is just some evidence-based counseling I wanted you guys to see. So people will ask about neonatal abstinence syndrome, and they'll say, like, what can I do to decrease my risk if I can't taper off, if I can't detox, right? We don't recommend tapering, and really interestingly, the dose that you're on of buprenorphine or methadone doesn't change your incidence of NAS. So if you're on 30 of methadone, you could have a baby with neonatal abstinence syndrome. If you're on 200, you could have a baby that does not have it. That's a genetic thing. We don't totally understand that science. They keep thinking it's got to be dose related. It's not. So you don't want to counsel women to be on like a lower dose to try and get rid of their risk of NAS, okay? And then if they do want to decrease that risk, somebody had asked me about psychotropic substances. The biggest thing they can do is stop smoking. So smoking increases the risk of NAS because baby can have an abstinence syndrome to any substance that it's dependent on. So nicotine, caffeine can affect it. Psychotropic meds can affect it. So antidepressants, antipsychotics can affect it. We do still recommend those in pregnancy because if a woman is in need of that, it will definitely keep her more stable, more sober, and be a better parent. We just talk to her about the risks and benefits, okay? But it does affect NAS. So the only thing I really want people in here to know about hospital care is that when a woman goes into the hospital, or if she has trauma, or if she has surgery, it is okay for her to get opiate medicines, okay? So if she has a baby and she's on a medication-assisted treatment, we don't say, I'm sorry you had a C-section, you have to take Tylenol. We don't do that. It's very normal to give women opiates after they've had a C-section, okay? Or even when they've had a vaginal delivery or in labor, they may get opiates, and that's okay. And the reason that's important is that that's good ethical medical care. It's not going to make her addiction relapse or worse. And so when you just want to follow her closely and you don't want to have a woman get in trouble because she got that in a hospital, okay? It's also very normal to have a short prescription of opioids. I have women in my state over and over again. They have a C-section. They get like 6 tabs of oxycodone to last them a couple days, and they come back to see me, and the insurance company stops their buprenorphine. So they say, we're not going to approve your Subutex anymore because you got oxycodone. And I'm like, if you were going to not approve one of them, like, please don't do this. But that's really important for you guys to know when it comes to advocacy and what's out there, is that there's a lot of barriers for these women, and that is not one that they need right after they've had a surgery. Breastfeeding on medication-assisted treatment is good. It is okay on methadone and on buprenorphine. It decreases the risk of NAS or the amount of time that they stay. What we want to make sure women have is monitoring, right? We want to make sure we're watching them and that they're okay. In my clinic, I'm following them every week, at least after postpartum, after they've had a baby, so I will know if something happens, okay? And we want that to happen in a non-judgmental and non-punitive place. In the hospital before I got there, they'd be like, we're going to, come here and we're going to send you to your pediatrician who has no idea how to do UTOXs, and we're going to have that pediatrician test your urine all the time. And she's like, moms are trying to get their urine tested in a pediatric office, which is really hard, and they don't have the right tests. It's kind of a mess. So we need to wrap around this care and make sure we're supporting women breastfeeding, right? Because it is recommended. National guidelines, breastfeeding is recommended. Okay. If you see a woman who is having, looking like she's falling asleep or looks like she might be intoxicated, there are several reasons for that. One might be that she has relapsed, and of course we want to find that out. But it could also be that she just needs her medicine dose to be adjusted, because when the baby comes out, that can change your metabolism. Or it might be that there's a medical condition going on. Or it might be that she just had a baby and she's really freaking tired, right? So we just want to make sure that we're assessing this and that we're not just saying, like, you're a bad mom, you've definitely relapsed because you just fell asleep. No, like, I fell asleep many times after I had my first baby, right? That's part of the game. So we're on a quick review. We've gone through a lot. There are a few take-homes I just want to go over, okay? Number one, if you're going to take anything, substance use disorders are chronic diseases, okay? I love this just because it shows that people with hypertension and asthma have higher relapse rates, right? Or higher risks of not taking their medicines and ending up in the hospital or having something bad happen with those diseases than people do with addiction, okay? So people with chronic diseases have a lifetime of working on those chronic diseases, and medicine's not perfect, but we don't say to a person with asthma, well, now I'm giving up on you. You're kicked out of my asthma program because you went to the hospital last week, right? So I don't kick people out. Once you're in my clinic, you're in my clinic. If you're not doing well, I don't kick you out. I see you more, right? I bring you in closer. This is so, so important, and our addiction treatment world is so backwards in that way. Like, sorry, you're out. What is that helping? Who is that helping? That's crazy. People want to treat this, right? They're like, go to detox and just get better. It's not talked about in society, and so we just want to sweep it under the rug. We just want to, like, make it go away, and it's not going to go away, right? And now I think with the opioid epidemic, we know that, right? We would need a massive, massive rug. We're never going to get there. So it's just got to come out. We got to talk about it, right? And we've got to treat it. Number two, we've gone over a lot of this, like risks of substance use disorders, okay? Obstetric risks are real, environmental exposure, real risks, and they're mitigated by appropriate treatment. So the way that we help these risks for opioids, medication-assisted treatment. For stimulants, it's actually, detox or having them stop with help, and behavioral health and environment, because unfortunately we don't have great medicines. For sedatives, like alcohol or benzos, safe, monitored detox. So we can't just say stop, because someone can die if they just stop sedatives or alcohol, okay? Again, methadone and buprenorphine are the treatments of choice in pregnancy. I just really wanted this last slide to take home. When you're treating opioid use disorder or recommending treatments, detox alone has a less than 5% success rate and can increase risk of overdose. So the last thing you want to do is just send someone to detox, pregnant or not, okay? No. Vivitrol's does not use in pregnancy yet. It might be someday. It has a 20% treatment retention rate, not as good as the others, okay? Science hasn't shown it really helping as much yet. We have more science to do. Somebody's in that 20%, right? I use it. I do have some patients who really want to do well on this. I use it for people who've been on buprenorphine or Subutex or Suboxone for several years and want to taper off. And then I'm like, okay, let's give you another medicine to kind of act as a safety net for a little while coming off of that and see how you do, okay? So it has a use, but I wouldn't go for it like, oh, it's the better option, okay? And then we have these national practice guidelines. They're in my talk. There's a website. You can look at them, but if you just want to make sure that I'm not making all this stuff up, I swear, national practice guidelines. These are for opioid use disorder in pregnancy, okay? And there are other guidelines to help with the other disorders. I have a lot of references through my talk. I have more. I can talk to you about it. I have tons and tons and tons and tons of papers. But thank you so much for listening. Sure. So we went over all of this material, and you're so brilliant now. Who has questions? I know I'm in the way of your reception. Yes. It is. So she brought up, hey, Suboxone and methadone are used recreationally also, right? Yes, okay. They are opioids. So methadone is extremely highly regulated, okay? So methadone can't be prescribed in a doctor's office except for pain, which is also like a whole other can of worms. but it's really regulated. It's in state dispensaries, right? This is state regulated and federally regulated. This is why we do that. It's a more dangerous medicine than Suboxone in some ways, but when highly regulated and used appropriately, it's a very effective medicine. That doesn't mean it doesn't get out there, right? It is out there. We know that. When it comes to buprenorphine, I will tell you, yes, it is diverted. Yes, it is out there on the street. So is oxycodone, so are all these other ones. People are really worried. Doctors are so afraid to prescribe buprenorphine because it's a treatment for addiction, but they're prescribing, even with all this stuff going on, so much oxycodone, so much other stuff, and they're afraid to the point that they're like, well, I'm not giving that person buprenorphine, but I might give them 5 oxys, and I'm like, oh my gosh, that's so much worse. That's gonna get out there. That has way higher street value than buprenorphine, and most patients who are using buprenorphine on the street are using it to not get sick. They're using it to help them through withdrawal. They're using it to try and get their lives back or to make it to work or whatever. And in the addiction treatment world, a lot of people believe that if we have enough of the treatment out there, the street value will actually go down. If you're on the street, trust me, my patients tell me all the time, Suboxone's expensive. And if you want a high, you're not gonna buy Suboxone. You're gonna buy something else to get a high, right? But people do buy it to use it to help them feel better. And so it is out there. You can get high off of it. If you haven't used, if you're not dependent, if you're a young user, you can get high off of it. So we do have to be careful, but it's still less likely to make someone overdose. So even if a young person is experimenting with opioids and they experimented with buprenorphine as opposed to heroin or oxycodone, they're way less likely to die. So that's why it's a safer medicine. Yeah. That's a really good question. Thank you. The question was, what's the best way locally to find a doctor that works with pregnant women who are opioid dependent? This is really hard. At ASAM, there are a big group of these physicians who have, the group that worked on those national guidelines. They're out there. They've been talking about having a registry or something so that people can find them. I would ask any physician who prescribes buprenorphine or methadone and find out from that community where the pregnant women go. So basically, somebody in the addiction community in your area that's prescribing buprenorphine or working at a methadone clinic, they know who takes care of pregnant women. So this is so hard. The question was, she's worried that methadone clinics aren't necessarily ethical. There's a lot of diversity among methadone clinics. Some taper people more and rapidly, and some don't give people enough medication. Some give people too much medication, right? So despite all of these incredible regulations, I've worked at methadone clinics, good ones, and in Camden, one of the worst methadone clinics I've ever seen is in my backyard. And it's so hard because I need it. It needs to be functional, and it's just not. It has to do with several things, right? Number one, they are so full. There aren't enough methadone clinics, and the clinics that we have are taking on tons of patients, because it's not like, oh, there are plenty of clinics to go around. They don't have the amount of funding that would allow them to have less patients and more providers, right? They still do wraparound care, but the problem is that with that many patients, like the one in Camden, it's just so overrun that really, I just don't think patients are getting the level of care that they need. Studies have shown that low doses of methadone are not effective. So giving somebody 30 or 40 milligrams of methadone, which is a low dose, actually doesn't help the addiction and is just putting more opioid out there and in the person. So to get that flooding effect to really work, you have to have what they call a treatment dose, which is like 60, 70, 80 and above, okay? So 100, 150 normal treatment doses of methadone. okay? If somebody's on over 200, some people have really high metabolisms, and women do go up and need more in pregnancy. So pregnancy aside, you just really want to be careful because over 200, there are really high risks, heart risks, and sometimes people do get really sleepy and they're on a really high dose. But good methadone clinics, which do exist, again, you can ask addiction providers in your area, can be excellent. And there are some really, really good ones out there that do tons of like close monitoring and care of their patients.
What's the resistance from behavioral health and substance abuse providers that don't want to work with any medication-assisted treatment? So like that's where I come from. And
Yes.
don't take anybody.
Yes.
They would detox when they take them if they're on methadone.
Yes. It's unbelievable to me. Yes. Yes. This is a great question. So her question is, what's with addiction treatment providers not taking patients on medication-assisted treatment, basically? So when you try to send someone to addiction treatment, which is that behavioral health, partial care, IOP, all that stuff we talked about, or even detoxes, okay? They won't take a patient if they're on methadone or buprenorphine. Sometimes not even if they're on Vivitrol, although that's going up. Sometimes they're taking them on Vivitrol. This is one of my biggest battles as an addiction provider. So I ask to talk to people's medical directors. My hospital right now is currently trying to partner with an inpatient detox center so that we can work and have our own like detox and treatment center. And I have interviewed program after program after program because I'm the medical director of addiction, and I say, like, my first question is, do you take patients who are on medication-assisted treatment? And if they say no, I say, why not, and would you? And if they say they won't, they're not our partner. It has taken a year. We finally found one, and even after I found that one, I talked to their medical director, and he didn't believe in that, and he used words like, I like my patients squeaky clean. I don't use the term clean. I know my patients might say clean and dirty, but that implies that when you have a disease, you're dirty in certain times. So I don't use that terminology. I don't say clean and dirty. I don't say junkie. I don't say any of these things. And people in addiction treatment field, if you hear them saying like some of those words, that kind of gives you, if you're calling like, is this a good one? Is it not? If you find a treatment program that's like, yes, we treat everyone the same, whether they need buprenorphine or Vivitrol or methadone or whatever, those people are on the up and up. They're figuring it out, right? It's so hard. So abstinence-based treatment has a huge, huge stronghold in our society. It's going to be there for moral reasons, right? People believe that when you're off everything, you're doing better. We still believe that. It's so interesting to me because I will use diabetes as an analogy, right? I have patients with type 2 diabetes. A lot of them have gained a lot of weight in their lives, right? And then they develop a disease. And that disease is in part genetic and in part because of their environment and what they have chosen to do in their lives, right? A big part of it is genetic. We know with addiction, a big part of it is genetic. And then some of it is environment, and some of it is what they've chosen to do, right? It makes a disease. That's what makes a disease. So diabetes has that disease. I have patients who have type 2 diabetes, who are able to lose 50 or 100 pounds and totally change their lifestyle and have really supportive partners and cook differently and work out differently. And they sometimes come off of medicine, right? That happens. It's a fairly small percent of my diabetes population, I will say, right? But it happens. So it's not to say that even with chronic disease, we can't change certain things and we can't recover. And people with substance use disorders recover, and they can change their whole lives. And it takes at least that much work, just like it would for somebody to come off medicine with type 2 diabetes, right? It takes that much work. We have to work at it so hard. We have done studies, functional MRI studies of people's brains in recovery. And when you've been in recovery for a long time, we find that the parts of the brain that changed and atrophied during your addiction or substance use disorder get stronger, and actually get stronger than the average bear, right? You get stronger than your pre-use disorder brain. So the parts of our brain, like we talk about the frontal cortex where we're not able to like put on the brakes, right? And you just have impulse control problems. We talk about the parts that are really tied into your amygdala and your fear centers and your seeking centers. You hear patients say like, I just have the desire to go and use or do something or fill something and I don't even want to use, but I have that desire and it won't go away. These are changes. These are physiologic changes in our brains, right? Those parts actually get stronger. So those people build muscles in recovery. So yes, people recover, right? But again, we need medicine to get there, just like my diabetics do. And I wouldn't ever just treat diabetes in my lifetime by saying like, I'm just gonna do diet and exercise and I'm never gonna offer anybody medicine. So the medical world is catching up. Science is there, but this like, it really started with Alcoholics Anonymous, post-prohibition in the 1930s. We were like, abstinence is the way. And then our, society really follows that. We have a lot of roots in a Protestant society. We have a lot of roots in a lot of religious components of society. And a lot of people believe that that's better. I believe in science. I also believe in humans and empathy and your ability to heal. All of this stuff comes into the play.
Are you talking about only
Okay.
during the pregnancy, or are you advocating for methadone use indefinitely after they deliver? I've never seen anybody get off of methadone through a methadone clinic, and I'm not talking about during pregnancy. So I just wanted to understand where you're going.
Sure. So they did a study. Now, this isn't like a perfect study. It was all men. Okay, it was all men who had been on methadone long enough to be what they would call fully recovered and reintegrated in society. So all men had jobs, had, they had several measures of like functionality in society, which is meaning recovered from a use disorder, right? They had to have a job, they had to be busy, they had to be integrated with social life, they were a sober social life, and they'd been on methadone for at least a year, but most of them many more years than that. And they offered them taper if they wanted to taper, right? So people offer taper all the time from methadone, and people try to taper. They offered those men so they could opt in, and then they followed them in this study over time. 80% of the people who tapered relapsed in the first year. So 20% of those people did not relapse in that first year, right? 80% did. It can be dangerous to taper. The way that methadone works, right, is it does increase your tolerance and dependence a lot, and it works that way. But it does mean it is hard to get off. That is a truth. It's also partly why it works so well. It's hard to get off, and when it's on, it's working. So we have this feeling that that person who's working and has a job and has a family and can drive and love and live, you would never know. When I worked in a methadone clinic, I had people who came and got a month's supply of medicine, and I saw doctors and I saw lawyers and I saw people who were in society, right? Some professions don't allow you to practice the way you were before if you're on methadone, but people you would never know were on methadone, and they were on medicine, and they were functioning in society. So it's up to us to decide, do we care if that person gets off medicine? Do I care if my diabetic patients get off medicine? Do I care if my asthmatic patients get off medicine? So it really depends on how we look at this, right? Some people, I've had a lot of success with methadone patients switching to Suboxone or buprenorphine, and then switching to Vivitrol because that's what they wanted for their lives, and they use different medicine and then maybe eventually get off. There are ways to do it. It doesn't mean that everyone has to stay on forever. But it also, for me, means that's not necessarily how I constitute success. So you're not successful in recovery because you're abstinent from everything. You're successful in recovery because you're living a full and happy life and you're part of society.